Hi everyone, my name is Jessica Hunter, and today I'm going to talk about ClinGen's Actionability Working Group. I'm going to start with a description of the Actionability Working Group, or AWG, and talk about how we define clinical actionability. I'm going to give an overview of the framework that we've developed to capture clinical actionability associated with genes. And then I'm going to show you where all the actionability products are available and give you some examples. Here's an illustration of ClinGen and the three overarching questions that ClinGen aims to address. For actionability, we're focused on this third question: is this genetic information actionable? And the overarching goal of the AWG is to find human genes that, when someone carries a pathogenic variant that's known to be associated with a serious health outcome, what interventions are available that can prevent or mitigate those future health outcomes now that the person knows that they carry this genetic variant? And to do this, we've developed a rigorous and standardized protocol to capture clinical actionability. We nominate genes and associated outcomes to assess clinical actionability. We produce evidence-based reports and use a semi-quantitative metric to generate actionability scores. And then we make these reports and scores publicly available on our website. For the structure of the AWG, we actually have two AWGs. The adult AWG is focused on clinical actionability in the context of adulthood, while the pediatric AWG is focused on clinical actionability in the pediatric period. And these AWGs are made up of different experts, including clinicians and researchers. Both the AWGs are supported by the knowledge synthesis team, which is the part of our team that actually goes out and looks into the literature and captures the available literature related to clinical actionability and generates actionability summary reports. The clinical context that we're working under when we're thinking of clinical actionability is that it's a person who's just been identified to have an incidental or secondary finding picked up through genome scale sequencing. So for the adult AWG, we assume the person is an adult. And for the pediatric AWG, we assume the person is an infant, child, or adolescent. We also assume that the person hasn't previously been diagnosed with a genetic disorder associated with the genetic finding they've just been identified to carry, though they may have signs or symptoms of the genetic condition. And the example that we use for this is that a person may know that they have high cholesterol and may even be receiving treatment for it. But what they didn't know is that they carry a genetic variant and a gene associated with familial hypercholesterolemia. It's important to note that we don't currently think about clinical actionability in the context of population-wide screening or diagnosis. We're really focused right now in the context of a secondary finding. When we think about interventions associated with clinical actionability, we're really thinking about well-established, clinically prescribed interventions, so something that your doctor would tell you to do. We also think about interventions specific to the genetic disorder, so we don't think about general things that people are recommended to do, like eat a healthy diet or exercise more. It must be specific to the genetic disorder being considered. And it should lead to disease prevention or delayed onset, lowered clinical burden, or improved clinical outcomes. And though we acknowledge that there are many factors associated with clinical actionability, we currently don't consider factors such as personal utility, reproductive decision-making, or ending the diagnostic odyssey. The types of interventions that we think about fall into the categories of patient management. This may include surgery, like risk-reducing surgery, or pharmaceuticals. We think about surveillance, and as well as circumstances to avoid. To give some examples of clinical actionability, for familial thoracic aortic aneurysms and dissections, is associated with an increased risk of dilation or dissection of the thoracic aorta. And some of the recommendations for this condition include frequent aortic imaging to detect and track aortic enlargements to guide aortic repair, as well as the use of beta blockers to slow aortic dilation. For malignant hyperthermia susceptibility, it's associated with an increased risk of uncontrolled skeletal muscle hypermetabolism after exposure to certain volatile anesthetics. So the recommendation for this condition is to avoid these triggering anesthetics and to use alternatives instead. I did want to note for the timing of interventions for the pediatric AWG, we think about interventions that are recommended to be initiated during the pediatric period. However, the outcomes that these interventions are meant to avoid, we think about the onset of these outcomes both in the pediatric period as well as adulthood. And so to come back to familial hypercholesterolemia, the example that we usually think of is that it's recommended if a person's identified with a genetic variant associated with familial hypercholesterolemia that they could start statins in childhood. But the outcome that they're aiming to avoid may be a cardiac disease that may not have onset until adulthood. For the AWG actionability framework, there are 3 overarching steps. Step 1 is generating the actionability summary report. So we start with identifying gene condition pairs to assess for actionability. We then have a rapid rule-out process to determine whether this gene condition pair meets minimal criteria for having clinical actionability. If it passes this rule-out process, we go on to draft a summary report for clinical actionability. And then the next step is to take this report and the AWGs review the report and generate scores for actionability using a semi-quantitative metric. The last step is that we take these reports and scores and then the AWGs make an assertion for actionability. So to start with step 1, we start with selecting gene disorder pairs. And though we call these pairs, it may be a pair, a single gene and a disorder. So for example, APC and familial adenomatous polyposis, or it could be sets of genes associated with the disorder. An example of this would be Lynch syndrome and the various genes associated with this condition. When we started with the AWG, we started with the genes recommended by the American College of Medical Genetics and Genomics for return of secondary findings. And then over time, we've added additional pairs that have either been nominated by us that we want to consider for clinical actionability, as well as outside stakeholders. For the rapid rule-out step, it's meant to quickly rule out any gene disorder pairs that doesn't meet minimal criteria for actionability. And our criteria includes whether there's evidence that this result is actionable in a patient who hasn't been diagnosed. There should be at least moderate penetrance, so greater than or equal to 40%. And it should be a serious health problem. So we don't consider mild or minimal health problems or traits such as eye color. So here's an example of the rule-out dashboard that we use to determine whether a gene disorder pair meets minimal criteria for actionability. So here is the rule-out dashboard from Brugada syndrome. So to zoom into the specific questions that we ask about meeting minimal criteria for actionability, there should be some sort of qualifying resource such as a practice guideline or systematic review. If that exists, we ask whether this practice guideline or systematic review actually recommends specific interventions. So it could be patient management, surveillance, or circumstances to avoid. If it does, for the adult AWG, we ask whether these interventions would be effective in an adult who has not been diagnosed with this condition yet. For the pediatric AWG, we ask whether there are interventions that are recommended to be initiated during childhood or the pediatric period in a child who hasn't been diagnosed, as well as whether this disorder presents outside of the neonatal period to allow a time frame to pick up on the genetic variant and implement an intervention. The next question is whether this genetic condition is a significant health problem. Then we look and see if there's information about pathogenic variants that have at least moderate penetrance, though we do allow for this penetrance information to be unknown because it's not always available. If it meets these 3 criteria, then we go on and say for the adult AWG to proceed with the summary report, or for the pediatric AWG, or for both. If it doesn't meet this criteria, then it doesn't pass the rapid rule-out step. However, we allow the AWGs to make an exception, and in this case, for Brugada syndrome, it didn't meet the criteria for at least moderate penetrance. However, both the AWGs granted an exception to proceed with generating a summary report for Brugada syndrome because in this case, though it didn't meet the criteria for moderate penetrance, it was still a significant health problem that had effective interventions available. So once it passes the rapid rule-out step, the gene disorder pair moves on to having an actionability summary report generated. So we've developed a structured protocol to make the search for evidence standardized and reproducible across curators. The idea is that each curator following the protocol would generate a similar actionability report. I will point out that the evidence search is not broad. We don't consider all aspects of the literature. We've limited it in scope to make our process feasible. So when we're looking in the literature, we're looking for clinical practice guidelines, systematic reviews, meta-analysis, as well as vetted resources such as OMIM, gene reviews, Orphanet, and clinical utility gene cards. What we don't include in the reports is narrative reviews and primary literature. Once we've identified all of our pieces of evidence, we tier them based on quality. So a tier 1 resource would be a systematic review, a meta-analysis, or a practice guideline based on a systematic review. Tier 2 would be practice guidelines or expert consensus that aren't based on a systematic review. Tier 3 would include all non-systematic evidence reviews, which would include OMIM entries and gene reviews that do cite primary literature for the information that they include. For Tier 4, it would be non-systematic review of evidence, again, such as OMIM and gene review entries that provide information without citations. And then Tier 5 would be a non-systematically identified source. So sometimes after we've identified on the Tier 1, 2, and 3, and 4 sources to include in the report, sometimes we may have gaps in the report. For example, in these resources, we haven't picked up on penetrance yet. So we may go out and non-systematically look for sources to provide that information. And so if we do include that source, we'll give it a Tier 5. Once we've identified all of our sources and tiered them, we then go through the sources and abstract data from the highest tiered sources first. So if we have the same recommendation from a Tier 1 resource and a Tier 2 resource, we'll pull it from the Tier 1 first. We abstract information related to 5 domains associated with clinical actionability. So we start with the nature of the genetic disorder, which includes the prevalence of the condition, any clinical features and signs, as well as natural history. We pull information related to available interventions or actionability, including patient management, surveillance, and circumstances to avoid. We also pull information related to likelihood of the outcome to occur, which includes prevalence of the genetic variants, penetrance or relative risk, and variable expressivity. We pull information related to the nature of the intervention, which we think of as risk and burden to the patient for undergoing the intervention. And then lastly, we pull the chance to escape clinical detection. So if this person wasn't known to carry a genetic variant, would they be picked up in the clinic anyway? So once we've generated the report, our next step is to calculate clinical actionability scores. And so we've developed a semi-quantitative metric to do that, to capture 4 domains of clinical actionability. So severity of the health outcome, the likelihood for the health outcome to occur, effectiveness of the intervention to prevent or mitigate the health outcome, as well as the nature of the intervention. So in order to calculate these scores, our first step is to identify specific outcome intervention pairs for the topic we're considering. So an example would be for hereditary breast and ovarian cancer, The different intervention outcomes we considered for this condition were breast cancer and mammography, breast cancer and risk-reducing surgery, and ovarian cancer and risk-reducing surgery. So for that topic, there were 3 different outcome intervention pairs that we scored. So to start with severity, the range of scores for this domain were from 0 to 3, where 0 is minimal or no morbidity, and 3 is the potential risk of sudden death. For likelihood, we score penetrance from 0 to 3, from minimal penetrance to moderate penetrance, or greater than 40% chance that the health outcome is going to happen. For effectiveness of the intervention, we score how effective it is from a 0, which is it's controversial and unknown to be effective, to 3, there's evidence that it's highly effective in preventing or mitigating the health outcome. Sometimes there actually may be information or evidence that the intervention is not effective. In that case, we give the effectiveness score a score of IN for ineffective, and in that case, none of the other categories are scored. For nature of the intervention, again, the scores range from 0 to 3, where 0 is the intervention has an associated high risk of morbidity, it's poorly acceptable, or it's really intensive, and something like this would be a gastrectomy to prevent gastric cancer. To a score of 3, indicating it's low risk, it's medically acceptable, and low intensity, so something like beta blockers that has really minimal side effects would get a score of a 3. For likelihood and effectiveness, we also rate the level of evidence. So if the interventions, to give an example for effectiveness, if the intervention comes from a tier 1 source, it'll be given a literature score of A. For the scoring process, we send the reports out to all of our AWG members. They individually rate each of the 4 domains to give a preliminary score. Then we all get on a call and discuss everybody's scores. And then after that discussion, everyone provides a final score. And these final scores actually may still differ among the different scores in the AWG. And of these final scores, we pick the majority, and that's the consensus score that's presented by the AWG. However, those individual final scores may disagree among the scores from the AWG. So some of the things that we think about when the AWGs are doing their scoring is that we may want to actually score some subgroups in a genetic condition separately if they're known to differ across the actionability domains. So some examples are that some of the genes may have different penetrance. So for BRCA1 and 2, for hereditary breast and ovarian cancer, we scored these genes separately because they had different penetrance for the outcomes for breast and ovarian cancer. We may want to score subgroups differently defined by sex. So an example would be hemophilia. It's an X-linked disorder, so we scored this separately for males and females due to difference in severity between males and females. Or we may want to score it differently for zygosity. For familial hypercholesterolemia, we scored it separately for heterozygosity versus homozygosity due to the varying severity. When scoring effectiveness of an intervention, we don't always have information from people with the genetic condition that we're considering. So sometimes we may want to pull effectiveness intervention from a different population and extrapolate to the condition that we're considering. And so in this case, the effectiveness score will reflect the intervention's effectiveness, but we'll downgrade the evidence score by a letter to account for the fact that we're extrapolating from a different population. An example of this is that we had effectiveness of aortic surveillance in Marfan syndrome based on available evidence, and we scored that as a 3B. It was highly effective, and we pulled it from a tier 2, so it got a score of a 3B. However, when we came to score Louise Dietz, we didn't have evidence that was immediately available from people who have Louise Dietz syndrome. So we extrapolated the effectiveness of the intervention in Louise Dietz from data that we had in Marfan syndrome, which is quite similar. But in this case, we downgraded the evidence score to a score of a 3C to account for the fact that we were extrapolating. Also, there are times that scores can choose to override the available evidence and give it a higher score based on their own expert opinion. And so an example is this: when we went to score familial adenomatous polyposis, we gave it a score of 3A for penetrance because though the available evidence met criteria for a 3C, it was tier 3 evidence that was available. It was felt by the experts that there was really sufficient information in the literature for it to qualify for a 3A, that it was very well known that FAP has very high penetrance. And so they overrode the available evidence level to give it a score of a 3A. When we score the effectiveness of a surveillance intervention, this one's really tricky because it's important to think when we're thinking of effectiveness is it's not the effectiveness of the surveillance intervention to detect the outcome, but more the effectiveness of the surveillance intervention to catch the outcome early and to allow for the timely intervention of downstream treatments to reduce morbidity and mortality. So an example of this when thinking about hereditary breast and ovarian cancer, for example, and mammography, we don't think of effectiveness in the context of its ability to detect a tumor in the breast or proximal effectiveness, but more about the effectiveness of mammography programs to reduce morbidity and mortality by catching breast cancer early. So to come back to the scores that are generated by the actionability groups, again, there's 4 domains of actionability that we score: severity, likelihood, effectiveness, and nature of intervention. We don't typically sum these actionability scores. We think of them as separate domains because to sum across scores indicates that they have equal weight, which may not always be the case. However, for the purposes of our assertions, we do sum the scores and use that as a starting point to generate our actionability assertions. So what we mean by actionability assertion is once the AWG has generated a report, calculated scores, they then make a more qualitative assessment of the level of actionability. So we've developed 4 levels of actionability. The scores are used to generate an initial assertion of strong actionability, moderate actionability, or limited actionability. And so total scores of 10 to 12 are given a preliminary assertion of strong actionability. Total scores 8 to 9 are given a preliminary assertion of moderate actionability. And any total score less than 8 is given a preliminary assertion of limited actionability. However, for strong actionability and moderate actionability, it's assumed that the intervention has at least some effectiveness. So if the effectiveness score of the intervention is a 0, all of these conditions are given a preliminary assertion of limited actionability. However, there's a 4th criteria we call definitive actionability. This isn't part of our preliminary actionability assertion. It's actually something that it would be a condition that scored as a strong, met criteria for a strong, but also met additional criteria that we've outlined, such as the penetrance comes from an unselected population. The effective evidence is not extrapolated. It comes from the exact population under consideration. And the effectiveness evidence is based on a direct impact of the intervention on the outcome. So we don't have an indirect chain of evidence. An example of this would be there's a surveillance intervention and we have evidence that this surveillance alone directly impacts health outcomes or improves health outcomes. So that means we have direct impact of that intervention on the outcome that we're considering. So this is our preliminary actionability assertion. However, our final assertion may change from this preliminary assertion. So what happens after the scoring process is that a preliminary assertion is calculated based on our final consensus scores. Then the AWGs discuss whether they agree with this preliminary assertion, and then they make a final assertion. And again, each individual score provides their assertion, and then the consensus assertion from the AWG comes from the majority assertion. And so the individual assertions may differ across scores, and then the consensus assertion is the majority. So similar to what we think about when we're generating scores, some of the things that we think about when we're making our final assertion, and the reasons the final assertion may be different than the original assertion, may be that we've determined it meets the criteria that we've outlined for definitive actionability. There may be limited evidence or poor quality of the evidence for any part of the score, which may make us want to change our final assertion. There may be an intervention that's widely used in current clinical practice that hasn't been systematically evaluated, as well as there may be high quality evidence or larger studies that aren't forthcoming or would be unethical. And so an example of this is for some metabolic conditions, there are dietary recommendations. However, there aren't larger studies to assess how effective these are, such as diet versus no diet, because it would be unethical to not give someone with this metabolic condition the special diet. So once we've finished the clinical actionability assessment for a gene disorder topic, the summary report, the consensus scores, and the assertions that we've generated become publicly available on the ClinGen website. Today, across the AWGs, we've assessed about 175 topics that have been released and are available on the ClinGen website. I'm going to show you some examples, but it has been noted that our website is going to be undergoing some changes soon, so it may not look exactly how I'm going to show you when you go to look at the website in the future. And our goal is for these products to be used by stakeholders to guide decision-making regarding the return of secondary findings based on actionability. It's important to know that these reports aren't comprehensive. Like I said, we don't do a comprehensive assessment of the available literature. We focus mostly on secondary literature, and so they shouldn't be used to guide clinical care. So if you go to the actionability web page on the Clinical Genome or ClinGen website, you'll come to this site. And some of the information available on this page, you can link to the Adult Actionability Working Group specifically, or the Pediatric Actionability Working Group specifically, and get more information about those groups. You can also get to some of the available documents that we've generated related to the assessment of actionability. So some of the papers that we published related to developing our protocol. You can find our scoring metric here. We've developed some training materials for our new scores for the AWG that may be helpful for someone to look at to learn more about how we assess clinical actionability. You can also get to our reports and scores under the category of tools and resources. So this takes you to a curation of the available topics, as well as to our interface where we curate the topics. So if you go to the Adult Actionability Working Group, this is what you'll see. You'll see the members in the group, as well as some of the related information, which includes our protocol. So we've published or made our protocol available on this page, which shows how we go about actually assessing actionability, how we pull evidence from the literature and the type of evidence that we pull. So to come back to the page before where you can link to the scores and the available reports, if you select curations, it will take you to this page where you can browse our curations. So the first is to show a list of all adult and pediatric actionability reports by topic, or you can focus on the scores in the adult context or the scores in the pediatric context. If you select the first option to take you to the list of all adult and pediatric actionability reports, it will take you to this page. So on the left-hand side, you'll see all the conditions listed. And on the right-hand side, you'll see some options. You can filter the report by context, such as adult versus pediatric. You can filter it by status, whether it's been released or whether it's currently in progress. You can export the associated information or use an API. To get to the reports, you can use these buttons that I've enlarged here. The button on the left will show you the rule out report for the topic in that particular context. The button in the middle actually takes you to the actionability report, and the button on the right will show you the different versions of the report because we do update them over time. So if you select to look at a report, here's an example of one of the reports from the pediatric AWG for MCAD deficiency. So at the top of the report, the information that you'll see is the status. So it passed the initial rule out. It's been released, so we've finished this report and it's publicly available. The final assertion for MCAD deficiency in the pediatric context is that we determined it had strong actionability. And below that, you'll see the consensus scores for the different outcome intervention pairs that we scored for MCAD deficiency. So there were 4 outcome intervention pairs, and each one has a separate score for the 4 domains of actionability that we score. Here's a different report for from the pediatric AWG for FAP. In this case, we actually changed the final assertion. The initial assertion for this topic was strong actionability, but because it met the criteria for definitive actionability, the final assertion was upgraded to a definitive actionability rating. And in this case, we provided a rationale for that. We usually provide a rationale when we do change the final assertion from the preliminary assertion to explain to the reader why we chose to do that. And so in this case, we noted that it met the criteria that we had outlined for definitive actionability and that the evidence for effectiveness in the intervention was from the FAP population. And the effectiveness in the intervention is supported by the fact that surveillance will lead to a more intensive intervention only if polyps are found. The penetrance evidence was also from FAP, although it was only available in adulthood. It wasn't available from the pediatric period. And again, below, here's the outcome intervention pair that we scored for FAP in the pediatric context. If you were to scroll down through the rest of the report, here are the different sections that you would find outlining clinical actionability for FAP in the pediatric context. So for severity of the outcome, we capture information related to prevalence of FAP, the associated clinical features such as signs and symptoms, the general and natural history of FAP. Next, we capture information related to effectiveness of the intervention. So here would be all the patient management interventions and the associated information related to how effective they are in preventing the outcome if that information is available. The next chance would be related to how likely it is for the health outcome to happen. So we capture information related to prevalence of the genetic variants, information related to penetrance of the different health outcomes. And then lastly, we capture information related to nature of the intervention or risk and burden of the different interventions to the patient. And then lastly, the chance for a patient to escape clinical detection. So if you were to go back to the browse curations, we just looked at the list of all adult and pediatric actionability reports by topic. If you were to come back to this site and say, I only want to see the scores in the adult context and selected that option, it would take you to this page. So again, here's a list of the different genetic disorders, and it would show you the different outcome intervention pairs that we scored for that condition, including the scores for the 4 domains of actionability. Again, there are some options in how you view this page. You can select column visibility and select different options for other variables you'd like to see for each disorder, including the status, whether it's been released, and other options for each report that's been generated. You can export this information or use an API. So some final notes for ClinGen's actionability working groups. We do regularly go back and update reports, particularly if we know that there's new evidence available that could potentially impact the scores that we generate. I will note that our assertions process is relatively recent. We only started making actionability assertions a couple of months ago. So when you go into the website and you start looking at reports, you'll know that assertions aren't available for all of the reports that we've generated. We've started generating them for our most recent reports and are working to go back retrospectively and generate assertions for reports that we've done in the past, but this will take time to do. So I've talked about what we've done for the AWG so far, but I do want to note that we are expanding our scope going forward. We're going to continue to curate and update curations for gene disease pairs in both the adult and pediatric contexts, but we're also planning on adapting our actionability framework for new clinical contexts to expand to thinking about population screening as well as polygenic risk scores. So with that, I want to thank all of the ClinGen AWG members. We have a huge collection of experts who have worked really hard to generate these resources, and I just really want to thank them for all the time and effort they've put into this work group. And with that, it will come back to me live, and I'll be happy to take any questions.